And this picture also shows us this neutrophilus. This neutrophilus means acute gastritis. And this model, this picture shows us the stage of chronic type B gastritis. Here is the normal, and then first is slight superficial gastritis. Some inflammatory cells, and here is the moderate gastritis. The inflammatory cells increase and infiltrate into deep. And this picture we can see the atrophy, the glands atrophy. This is also slight, and this is the moderate. And later we can see the layer of mucosa is thin, and we can see the complete atrophy of glands here. So from pathological view, the chronic gastritis can be divided into superficial gastritis and atrophy gastritis. So this is a special erosive gastritis. Here we can see this one shows us the coagulation of necrosis of proteins, this area, without nuclei. And the second, here shows us the destroy of the surface epithelial cells, here. And 1, 2, 3. 3, this is the normal. Intact mucoid glands, this is the normal glands. And here is erosive gastritis. So this is one kind of classification of gastritis. According the infection, the number of HP infection, you can divide it into mild, moderate, and marked, different degree. And also according the number of neutrophils, according the number of the chronic inflammatory cells, mononuclear cells. And here, according to the glands, the number of glands and the metaplasia of glands. Here is the atrophy of antrum. The glands decrease here from mild to the marked. Here also this is the acid produced glands. And here is the intestinal metaplasia. We see the goblet cells increase. So this HP, the different cells and the glands, the atrophy and the metaplasia of glands can, according the number of this, can be divided the gastritis into mild, moderate, and marked. And we have mentioned this intestinal metaplasia. So intestinal metaplasia can be divided into complete intestinal metaplasia and incomplete intestinal metaplasia. I think we already learned this definition, intestinal metaplasia. So what's the difference between completely intestinal metaplasia and incomplete? What's the difference? No response. So for the complete intestinal metaplasia, here show us this kind of cell, intestinal resorptive bush-bird cells, here, these cells. And plus or with these goblet cells, this epithelia, we call it complete intestinal metaplasia. If only this goblet cells, or this gastric mucosa epithelial cells plus these goblet cells, then we call it is incomplete intestinal metaplasia. So the third type, type C gastritis, is chemical gastritis. Here we can see, from this picture, we find the mucosine content of surface epithelial cells decreased, reduced. And we find the papillary feveral hyperplasia, this hyperplasia papillary. And the third character is there is little or no inflammation. Although it is gastritis, but without inflammation, just the reduced mucose content and this hyperplasia. This picture also shows us this is the chemical gastritis. Without inflammation, reduced mucosine produce, and also this papillary hyperplasia. So there is another type of gastritis. For example, lymphocytic gastritis, granulomatous gastritis, many, and eosinophilic gastritis, phlegmonous gastritis, and the gastritis associated virus and parasites are different, but they are not common. So we focus on this chronic and chronic gastritis, including three types: type A, B, and C. The complication of type B and type C gastritis is bleeding. It can cause this anemia. And the second is erosion and ulceration. And this ulceration can cause this perforation and cause this inflammation, peritonitis. The third is scarring. And for type B, gastritis is associated with lymphoma, mild lymphoma, and some are also associated with stomach carcinoma. So here is pathological classification of gastritis. Usually when we do autopsy of stomach, biopsy of stomach, when you go to the hospital to have a check, the pathological report, the diagnosis will be chronic superficial gastritis or the chronic atrophic gastritis. And for this type, is much more associated with the tumor, with the carcinoma. And we will also give the report about whether there is intestinal metaplasia or this schedule pyrotic metaplasia. So the main gastritis is chronic gastritis. And for acute gastritis, we said it's an acute mucosal inflammation process. And this kind of gastritis, usually we will find a hemorrhage into the mucosa, usually. And in more severe circumstance, we can see this superficial mucosa destroyed. We can see the erosion of mucosa. And this erosion will cause this acute gastritic intestinal bleeding. This is the main consequence of acute gastritis. For the pathogenesis of acute gastritis, first is some drug is anti-inflammatory drug, aspirin, for example, the use of aspirin. And another is this alcohol or the heavy smoking. Sometimes it's some chemotherapy drug for the cancer. And some also bacteria, urine, some stress, some caused by shock, and some acid and other regions. So there are many causes can cause the acute gastritis. For this acute gastritis, we divided it into these subtypes: infective and corrosive gastritis. Morphology, from morphology, in the mild form of acute gastritis, we just see this moderate edema and slight vesicular congestion. This is similar of the inflammation in other organs. The surface epithelia is intact, and there are several neutrophils are present among the surface epithelial cells, or with the epithelial layer and the lumen of mucosal glands, little neutrophils, just edema and slight vesicular congestion. And when these neutrophils above the basement member, this means active inflammation. Here, activity. What's the meaning of activity? When we see the neutrophils above the basement membrane, that means the neutrophils within the epithelial space infiltrate the epithelial cells, then it is active. But for the severe mucosal damage, erosion and hemorrhage develop. For this kind of severe acute gastritis, we can see the epithelial cells destroy or lose all the epithelial cells, and the generation are detected in the mucosa. When it does not cross the muscular mucosa, we call it erosion, not the ulceration. This is the difference, erosion and ulceration. What's the meaning of erosion? Just the loss of superficial epithelia and did not cause the muscular mucosa. And when we find the co-current erosion and hemorrhage, this kind of gastric, we call it acute erosive hemorrhagic gastritis. So here show us, this is the mucosa of stomach. We can see the hemorrhage, is red peak. And here on the microscope, we can see here, this is the necrosis in the lumen. And here we can see the erosion. The superficial epithelia destroyed here. Here is the epithelia. Here we can see the destroy of mucosa, but it is limited in this mucosa, so we call it erosion. For the clinic feature, depend on the severity of the anatomic changes. acute gastritis may be symptomatic, but usually also will find this the gastric pain around the stomach, pain, vomiting, and so on. For the hemorrhage, we can see the massive hematomasis, melena, and sometimes we can see the fetal blood loss. This we can detect it by the by the reagents and the test. And one of the major cause of massive hematomasis is in the alcohol patient. 25% of persons who take daily aspirin for this kind of disease will develop to this acute gastritis, many with bleeding. So when you when a patient come to the hospital, say some clinical feature, and you can ask whether he take these drugs, aspirin. So this is the first disease of stomach, gastritis. And the second, we will introduce peptic ulcer. So this is different concepts, ulcer and erosion. Ulcers are defined histologically as a breach in the mucosa of the alimentary tract that extends through the muscularis mucosa into the submucosa or deep. So it is deep. And the erosion is only a breach in the epithelia of the mucosa, limited. It is not so deep. Ulcer is deep than erosion. So what kind of organ will you think? What kind of organ? Stomach. We can see these folders. This is stomach. And here we can find ulceration or the ulcer. Here is small ulcer. The character of this ulcer, this is not so big. It's small. It's small. The bottom is clean. It's flat, clean, and the mucosa surrounding this ulcer, we said it's star-like mucosa folders. This is the character of peptic ulcer from the close view. This is very important. It is to distinguish the benign ulcer from the malignant ulcer. And here, on the microscope, we also find this ulcer. So it's deep from mucosa to the submucosa. And usually, for the typical peptic ulcer, we find four layers on the microscope. And here only show us 3 layers. First is fibrinoid necrosis. Second is granulation tissue. Third is scar tissue. From here, this is the ulcer. This is necrosis, granulation tissue, and then the fibrosis or the scar tissue. Now, this area, this defect is not so deep. We call it the erosion, because of the gastric acid reflux. Then the duodenal will occur this erosion, and this erosion, we can see this black area is hemorrhage. Hemorrhage is bleeding. this area. So now let's have a summary for the peptic ulcer. Usually it's solitary lesion less than 4 centimeter in diameter. It's smaller. And located in the following sites. This is a favorable location of peptic ulcer. For the duodenal peptic ulcer, always usually occur or located in the first portion. And for the stomach, usually located antrum. So this is a favorable anatomy area. The peptic ulcer at the gastric esophageal junction in the setting of gastroesophageal reflux or Barrett esophagus, this area. So this is the peptic ulcer. It's small, it's deep, it has a favorable location, and it has closely, it has this star-like borders. And here show the causes of peptic ulcer. Normally here, this is normally the mucosa have some defensive forces. For example, on the surface we can see mucus secretion. They are covered with this mucus. And also some mucosal blood flow. This is also protect the mucosa. This is defensive forces. And another side, damaging forces, mainly to gastric acidity, gastric acid. And the second is peptic enzymes. So normally they are in balance. So when HP infection, when the patient have take these drugs for aspirin or this drinking or the secreting, then this damage force increased. And when this defensive force decrease, so then the patient can digestive his organ. So we can find the ulcer here. Here show us the 4-layer necrotic area, necrotic layer, and then is the non-specific inflammation. And the third is granulation tissue, and the fourth is fibrosis. This 4-layer for the typical gastric peptic ulcer. And here we have introduced in details of these 4 layers or the 4 zones. So on the base and the margins of this peptic ulcer, we can find a superficial thin layer of necrotic fibrinoid debris. This is very thin layer. And the second, beneath this layer is a zoo of non-specific inflammatory infiltration. Usually it's the neutrophils, predominant neutrophils. Third, in the deeper layer, we can see granulation tissue. There is active granulation tissue. So under microscope, what can we distinguish? This is granulation tissue. And the fourth is the old granulation tissue. That means the granulation tissue developed to this fibrosis to the scale. And in the deep of this peptic ulcer, we can see some vessel wall will with the scared area typical thickened. The vessel wall will thickened by surrounding inflammation and are occasionally thrombosed.